Well, welcome to the daily brief on Metro Milwaukee's health and the economy, brought to you by the Medical College of Wisconsin and the Metropolitan Milwaukee Association of Commerce. My name is Tim Sheehy, president of the MMAC, and I'm joined by my co-host, Dr. John Raymond. Today, we will again deliver a 19-minute fact-filled update on the health and economic impact of COVID-19. This webcast is powered by Aurora WDC. Our special guest today is Kathy Jacobson, the president of Freighter Healthcare, a great asset to both the health and the economy of Metro Milwaukee. So Dr. Raymond, I'll turn it over to you.
Thanks, Tim, and good afternoon, everybody. The first slide summarizes various indicators of COVID-19, and I'll run through these quickly. The doubling time for COVID-19 continues to stretch out now to 13.9 days in Wisconsin and 19.3 days in Milwaukee. The daily growth rates are stable at 4.3% in Wisconsin and 2.8% in Milwaukee. There were 314 positive tests in Wisconsin today, with 53 in Brown County and 104 in Milwaukee. And there were 5.7% positive tests in Wisconsin, which is improved, and 11.5% in Milwaukee. COVID-19 diagnostic testing capacity is stable at 14,800 diagnostic tests available today. ICU and ventilator capacity are stable and they are adequate. And PPE trends are improving or stable in Wisconsin and Milwaukee, with the most critical shortage currently being of medical gowns. Next slide, please. Several of you have reached out to ask about the significance of recent reports of a COVID-19 mutation. And as background, this slide shows how COVID-19 invades human respiratory cells. The COVID-19 virus is shown on the left as a round gray ball that's studded with red spike proteins. In the middle, you can see the COVID-19 spike protein represented like a yellow tulip with a blue stem, and it binds to ACE2, which is a protein on the surface of a human cell, and then enters the cell and then replicates in the cell by hijacking its internal machinery, and that causes the infection. Now, the mutation that we're talking about is shown in the middle of the screen as D614G, and as you can see by the red vertical line and the red dot, that this mutation influences the spike protein itself. Next slide, please. Okay, so researchers have detected a possible fitness advantage for this COVID-19 strain with a mutation on the spike protein, and this is called the G lineage, and it might enable a more rapid spread of the disease. The original Wuhan strain is called the D lineage, and the reason why people think this G lineage might confer a competitive fitness advantage is that it's much more prevalent in Europe and in North America. And for any science buffs, the G lineage just simply changes a single amino acid, aspartic acid, to glycine in the spike protein. So the real question is, does this increase the transmissibility or the infectiveness of the COVID-19 virus of the G lineage? Or is it just lucky or fortuitous that the mutation happened when there was transmission in Europe and North America? And what I can say is there's currently no evidence that this G lineage is more infectious or more dangerous than the old Wuhan D lineage. And with that little bit of science, I'll turn it back over to Tim.
Thank you, Dr. Raymond. And once again, you've updated or upgraded my capacity for Scrabble games now. So I appreciate that very much. Kathy, I want to bring you into this conversation and have you talk a little bit about, from Freighter's perspective, how you see the transformation of this COVID crisis. And then kind of a secondary question to that is, we've certainly got a lot of questions as we've talked about slowly opening the aperture to the economy. And can you tell us kind of what you're seeing kind of across your institution and other healthcare institutions in dealing with the COVID crisis?
Yeah, sure. Let me start. I have to start, first of all, with a thank you to everyone on the phone, because I know members of the MMAC have all sacrificed ostensibly to protect our community, but to connect to our healthcare systems, quite frankly, as we prepared for this crisis. I have been in healthcare for over 30 years. And I will tell you, from the middle of March to about the middle of April was one of the most literally scary times I've ever been through, in terms of unprecedented uncertainty, preparation, that we had to go through. And it was really scary when those case rates were doubling much, much faster than what John was able to show us today. Social distancing works. The Safer at Home program worked. And we have been able to flatten the curve, and we were able to avoid a crisis in our healthcare system. So I think that is one thing, number one, that we proved, through this. So from our perspective, we managed our way through this. We peaked about mid-April here in southeastern Wisconsin, and we stood there for a little bit, maybe for about a week or two, and have been pretty much on a steady decline, ever since then, and are now running, I'd say, at about half. Maybe 2/3 about where we were at peak. So COVID-19 is still present in our community. Of course, we all believe it's going to continue to be present in our community for quite some time. What I would say is different from where we were in the middle of March is a couple of critical things. We have learned a lot, all of us across our healthcare systems, and we are meeting at least twice a week right now. The CEOs of the healthcare systems have been meeting pretty routinely. Our chief medical officers are meeting more often to put together coordinated regional plans. And we have surge plans. We know where we would go if the cases increased. We have safety plans in place. We know our limitations and how to measure them on protective personal equipment, which has quite frankly been one of our biggest limitations that we've been dealing with probably more than anything else. And so I think that all of us would say uniformly, if we were here, we are much, much better prepared. We do expect as things do start to open up, even if they phase open, that we will see more cases. But the whole point is that your healthcare system is ready and able to take care of that. And I think any of my colleagues would tell you that we feel much, much better prepared for that than we say we were in the middle of March. So as we start thinking about where we are today, the other major concern that we have had during all of this time, especially once maybe that first month when we started to stabilize, is that we're deferring everybody else's healthcare. So as we started to make room for a surge that we expected to see, we started deferring healthcare. Whether that was surgeries, whether that was procedures, whether that was diagnostic tests, whether that was screening. We didn't want people coming into our facilities, hospitals or clinics, unless we could ensure that they were safe. There was a very rapid transmission to video telehealth across all of our healthcare systems, but that doesn't take care of everything, that you have to in terms of healthcare. So we have been concerned for quite some time, that we've been deferring healthcare. And so towards the end of April, when we could start to see those declines, we did all start to think about how do we bring this back online. And so those are the preparations that we're really in the middle of right now. Some of it is starting to open up. We have safety plans in place. We have social distancing in place. We have universal masking in place. We have pre-op testing in place. We are testing every inpatient, everything that we can do to keep our environment, our staff, and our providers and our patients safe. And so that's really the next phase that we're entering into right now.
So Kathy, the message to people who are looking to have a procedure done or surgery that they've delayed from Freighter and other healthcare providers is what? We're in our own smart restart. You can start to come back into these facilities.
So we are proactively reaching out first so that we make sure that that's prioritized. So for example, when Safer at Home went in place, we pushed off all of our ambulatory schedules and our surgical schedules until May 1. Well, when Safer at Home got extended, that's when we really had to call and say, we can't go another 30 days. Some of these folks need to start getting in here. So really right now, it's mostly in our hands, really particularly on surgeries. This isn't just open the schedules, we have to prioritize. How are we gonna bring folks in? So who are the next most urgent? We've been seeing urgent cases all the way along the line, but how do we start moving into that intermediate category for people who are going to have further deterioration, they're in pain. And so we're reaching out, the doctors are reaching out and prioritizing the surgeries and who gets to come in. In terms of folks who are on our ambulatory schedule, same thing. We are in a video first mode If you can be seen through a video visit, that's still what we want you to do to keep you out of the clinic so we can do social distancing. If you can't, we need to bring you in, but we might need to move your appointment so that we don't crowd up our waiting rooms. We might have to have you wait in the car until it's safe for you to come in. We want you to wear a mask when you come in. So we are proactively reaching out to people right now. I think you're going to see that mode of operation very similar across all the healthcare systems pretty much for the month of May, so that we can prioritize the deferred healthcare. And we're really hoping that we get back into more quote unquote normal by the time we get to June. The one thing that I would add to that though is that what we have seen, especially towards the end of April, is people deferring healthcare on their own. And they're really people who need to be seen. You know, so we've seen our emergency room cases are down by 50%. That's not because all of that was discretionary care. We are seeing incidences and episodes where people have damaged their health because they're not getting health care that's needed. So we need to get the message out about that our facilities are safe and that we're taking those protective steps, but we are concerned that patients will not willingly come back into the environment when they really need to be seen.
We talked a little bit about this, but can you talk about the role of Froedtert Health and other healthcare systems in testing? So as you mentioned, as the economy comes back online, there's going to be more contact, there are going to be more cases, and what role can Froedtert and others play in helping companies and their employees with the testing process?
Yeah, sure. So I mean, I will tell you, back in the early, probably we've had the COVID test available in our lab, and we have run a reference lab as well as a hospital lab, Wisconsin Diagnostic Lab, since the middle of March. So we were very early in on the COVID testing, but what we struggled with for a very long time was getting the supplies. So supplies are very specific to the machines that the lab uses. The vendor supplies their own supplies. We're very lucky at WDL that we have a diversity of machines, but even so, we were really struggling with getting supplies. So we always were able to take care of any patient, even in an ambulatory setting that had symptoms. That was not the case across the board with different healthcare systems. At the same time, turnaround time skyrocketed, especially folks who were dependent on these national labs. We've always been able to keep our turnaround times at 12 hours and under. I'm hearing hospitals across the state who are still 4 to 6 days out, which is a problem when you're trying to diagnose. So as we start thinking about how we help businesses, the capacity's gotten a lot better. Particularly in April, the reagents did start to flow. There's been a lot of new access to supplies coming out of Madison and Exact Science and helping the National Guard. What we're trying to figure out now is what role should health systems, the National Guard augmented with public health, because they are setting up sites now, you know, particularly in hard hit parts of Milwaukee, play to enhance capacity. And then how do those of us who have existing relationships with employers already use our capacity for those folks, and really trying to coordinate so that there's a universal expansion of capacity and not just tripping over each other. So that's something I think as the capacities all come online that we're working through. We had that on our phone call this morning as we had our regional coordination going on. So that's something that, you know, I think is still a work in progress. I would say if you have a relationship already with a healthcare provider, either occupational medicine, employer health, go to that provider first. That's what we all talked about this morning. Advocate Aurora, Ascension, Froedtert Health, so that if you have an existing relationship and you want to know how you get access to testing to come back online, go to those folks first. Okay. If you have an outbreak that exceeds any of our capacity, we will go to the National Guard or other sources to get backup on that. But we really all agreed today that if you have a relationship, go there first. That's the first place to go.
Very helpful. Dr. Raymond, we'll bring you back in, and Chris will go to questions from our viewers.
Yeah, the first question we got asked is one that may be appropriate for all three of you. Somebody asked whether it's possible to project how the rates of infection and death may go up as we reopen our economy. And I think an important point is it depends on how we reopen our economy and what steps businesses take as we reopen.
Dr. Raymond, Kathy, I'll let you take that.
Yeah, John, probably you would know better on the rates.
It's really hard to know because we can only look at China and some of the countries in Europe as examples. And especially in Europe, they're only a few weeks ahead of us. But we have lots of metrics that we can follow to track whether the infectivity is going up or whether we're having a surge in our hospitals. And I think those are metrics that we really need to pay attention to. The death rate is another one. But again, probably the most important one would be hospital capacity.
Right. And I know from our perspective, we're monitoring cases, percent positives, so that we get that early warning. You know, the last thing I want to do is find them in the hospital. We want to see that stuff going up first. And we actually have that as part of our surge planning. And we are doing that regional coordination among the health systems. John's working with us too. What are those monitoring metrics so that we get a heads up if we know that we have to go back into a surge preparation?
Another question we have is, what is the policy for testing hospital employees at this point?
I can go ahead and take that. So we do temperature checks every single day. Everybody who comes to work every day has to certify that they did a temperature check and that they're valid to be able to come into work. So that's been long existing for some period of time. Obviously, symptomatics, you get tested, you get contact traced. We look for everybody who you've had exposure to. We quarantine, all those national, all those standards, in terms of what we're doing with that. What we are looking at right now as testing capacity has come more online is what is the efficacy of broad-based testing, especially as antibody testing becomes available. And I know John's talked about that here. That's, there's still some things to be decided there, but you have to really look at high risk, low risk, and prevalence before you really do widespread testing. So really we are testing in our high risk patient units. So where we have patients that are the most immunosuppressed, most at risk, our sickest patients, those are the first places where we're going to put more testing capacity in, starting with the availability of antibody tests, and then if needed, going to the COVID test. But we're going to be doing it based on patient risk as we expand healthcare worker testing.
Dr. Raymond and Kathy, if you have a perspective on this too, we'd welcome it. Do you expect the virus to mutate again, and would this affect the pursuit of a vaccine?
Yeah, John, yeah.
It's going to mutate. It's been mutating about once every other week. And so far, as I mentioned a little earlier in the talk, none of the mutations have shown any significant difference in terms of their contagiousness or the impact on people. In terms of whether that'll have an effect on vaccines or not, sure, it could. If there are enough mutations, the vaccine that we make based on a current mutant might not work in the future. But I would say for the short term, the next 6 months or so, we probably shouldn't worry so much about the mutations. We're going to have so many different vaccine options online that at least one of those we're hoping will be effective.
Along those same lines, do the mutations make it any more likely that someone can be infected more than once?
Not up to this point. I think it's very unlikely. Most of the mutations are what we call silent mutations. They don't affect the protein structure, which is what antibodies recognize. So far, no.
Kathy, we had a question about what can you do at Freighter to build a greater confidence in care and make people feel safe as they come in for procedures?
Yeah, I think we have to communicate on what we're doing. I think, and that is something, if any of you are a Freighter patient, you should be getting emails from me, that tells you about what we're doing, to let you know what we're doing with our healthcare workers, what we're doing with cleaning, what we're doing with masking, what we're doing with testing. Every single inpatient patient at Freighter, at all of our hospitals, every single pre-procedure, pre-surgical patient is getting a COVID test. So again, in the most vulnerable areas, we're making sure all that's happening. Out in the clinics, again, social distancing, masking, cleaning, all of those different types of things. And again, I know my colleagues in the other health systems are doing that as well, is getting that message out that if you need healthcare, you're better off to come in and get your healthcare taken care of because we're in a safe enough environment as opposed to taking a risk with your health. That's what we're really concerned about, is that people have been choosing, fear of COVID infection over something that's urgent and they need to get taken care of. And we are seeing cases of that, where people have deferred their healthcare for too long and it's ended up with a detrimental effect.
Kathy, we also had a question, a good question about how difficult it is to orchestrate a temperature check for all employees and what you're finding from those. Are you finding a lot of people with elevated temperatures?
No, and quite frankly, we have very low prevalence of any kind of COVID in our healthcare workers, very low. You know, so I can tell you we monitor, I mean, anybody who even comes in asymptomatic, I'm not kidding, no more than 1 or 2 a day, and I have no idea if they got it at work or at the grocery store. Very, very low prevalence. So we are relying on self-certification because we have thousands of people who work here every single day. Every day, they have to come in and certify that they took their temperature. And then if we have a symptomatic, they are tested immediately, less than 12-hour turnaround. I know if they have COVID or not. We follow routine, but I will tell you our prevalence and our testing rates are extraordinarily low in terms of incidence in healthcare workers.
One last question, and this is an issue that's come up a few times. Is there an ultraviolet light that someone can recommend that can help disinfect a frequently touched surface?
We know that UVC wavelengths will kill the virus. As far as I know, the UV light has not been deployed in a systematic way to kill COVID-19, but it could. Kathy, are you thinking about that in any of the freighter facilities?
No, I mean, we're using, you know, the UV has actually been applied mostly to the masks, you know, in terms of how we clean. I mean, just cleaning. That's all I can say. You know, I mean, there's many standards out there. We found out from corporate real estate has standards out in terms of cleaning. If, you know, there's different standards obviously inside of a hospital room, but we run large corporate offices also as well. There's many standards out there for the best way to clean COVID-19.
And never to be used internally.
Please don't. Otherwise, you will be in our emergency room.
Dr. Raymond, Kathy, thank you very much for joining us this afternoon. And Dr. Raymond and I will be back tomorrow with a wrap up of the week. And I believe Mayor Barrett will join us. So again, have a healthy, safe rest of your day. And Kathy, Dr. Raymond, again, thank you very much for your time.
Thanks, Tim. Thanks, Kathy.